Holding this webinar on the very last day of Pulmonary Fibrosis Month, because the APF theme for the month this year has been the impact on cough on all of our lives. Most pulmonary fibrosis patients suffer from a persistent and uncontrollable cough at some point along their journey. To mark Pulmonary Fibrosis Month this year, we ran a survey of our community and we really received some startling results. Over half, 57% of you, say that your cough affects you every day, and 50% worrying that it makes you, from at least at some point of the day, feel like you can't breathe. Despite this, despite the obvious effect of it on us, on our lives, 70% of us say the biggest concern is the reaction and judgment of others, particularly in times of COVID, with over half of us, 53%, feeling embarrassed by our cough. And I've got a persistent cough now, also even after my transplant. A pulmonary fibrosis cough can't be controlled and is not contagious. I know that, you know that, but other people listening to us don't know it, and it's very embarrassing and difficult for us. This evening, we've got a chance to answer some of our questions about cough. I remember when I was first diagnosed with IPF in 2008, I asked my consultant, what can you do about this cough? And she said, sorry, there's nothing we can do. I think things are getting a little bit better than that, but we'll hear a lot more of that tonight from our main speaker, or not main speaker, but first speaker, Professor Surinder Birring. Very warm welcome to Surinder, who is a consultant respiratory physician and professor of respiratory medicine at King's College Hospital and at King's College, University of London. Professor Birring is a leading research into mechanisms and ways of monitoring and treating cough. So really look forward to hearing his talk in a short while. Our second speaker tonight is Liz Robertson, who is from the Windsor Pulmonary Fibrosis Support Group. Liz was diagnosed with non-specific interstitial pneumonitis, NSIP, in 2011. The diagnosis was subsequently changed to rheumatoid arthritis, ILD, when inflammatory arthritis was diagnosed in about 2013. Cough affects every part of Liz's life, and her cough has made her have to give up work. So Liz will be talking to us after Surinder has. The format is going to be, as I say, Surinder first, Liz second, and I'll have a conversation with Liz about her personal experiences of living with cough and what has helped her manage this. After that, there's going to be a good opportunity for everybody to answer questions. We'd like you, if you would, to put your questions, formulate them as short but complete questions, and put them in the Q&A box, not in the chat. Okay, if you look at the bottom of your screens, the Q&A box, not in the chat. If after the talk, you still feel we haven't answered your question, please turn to the excellent pages on cough on the APF website. And if you still have questions, do feel free to contact us. But first of all, we'd like to find out a little bit more about you and put a poll question up for you. Are you a patient, a carer, a friend, a family member, or a healthcare professional? So how are we doing? Great. Well, we have 216 people here tonight, which is absolutely amazing. And as expected, nearly 3/4, 74% are patients, 4% are carers, 4% friends, and 19% healthcare professionals. This is really great. I think this is a more patient-focused webinar almost than any one we've had. So it's clearly a topic that really is of importance to patients. So now it's, without further ado, it's really great pleasure to invite Surinder to talk to us about clearing the air about cough. So over to you, Surinder.
Thank you, Steve. It's a pleasure to be here, and thank you to Action for Pulmonary Fibrosis to invite me to present today. I run specialist clinics in cough, interstitial lung disease, and sarcoidosis, and for many years. And this has given me a unique opportunity to study both conditions. Now, cough may be the first symptom of pulmonary fibrosis, and for some patients, it's the worst symptom impacting their everyday life. And Steve touched upon how this problem affects patients. So I'll start by asking the question: what is the purpose of cough? It's a key protective reflex. It protects the lungs from aspiration of food or mucus in the throats going into the lungs, where it would cause damage. A second important function is to clear mucus from the airways and lung. And again, if there was stagnation of mucus in the lungs and it wasn't cleared, that would cause damage too. So cough has a very important protective function in everyday life. So when does cough become abnormal? Well, we all experience it regularly, and this is when we get the common cold. A virus hijacks the cough reflex, and the cough nerves become hypersensitive or active. The cough does pass in a few days. The hypersensitivity of the cough nerves in the upper airways does pass in a couple of weeks or so. Now, chronic cough, it is different. It usually indicates chronic lung disease, of which pulmonary fibrosis is one. Now, today I will start by beginning. I'll start by discussing causes of cough in general, and then cover how the specific mechanisms by which fibrosis causes cough. I will also touch upon treatments and research into treatments for cough in fibrosis. So, next slide, please. So cough in pulmonary fibrosis is very common. This is data from idiopathic pulmonary fibrosis. Up to 80% of patients are affected. It really impairs the quality of life of patients and can cause severe complications. And one of the more frequent and troublesome problems associated with cough is urinary incontinence, particularly for female patients. Up to 2/3 of females with chronic cough will have some degree of urinary incontinence. Unfortunately, there are no approved or licensed treatments for pulmonary fibrosis cough, but this is very much an area of active research. Now, the figure at the bottom of the slide is just to remind me that it shows the amount of coughing during the day, the cough counts measured with a digital cough counter. And what this shows is that patients with pulmonary fibrosis, IPF being a typical example, the cough counts are really up there with other chronic lung disorders, more than asthma in this series, and as much as patients with a pure chronic cough who don't have an underlying lung problem. So next slide. So how does fibrosis cause cough? Well, there are several potential mechanisms, and it does vary from patient to patient, and multiple mechanisms are possible. And I think this is probably one of the explanations for why the characteristics of the cough does differ from patient to patient. And it can be challenging to try and work out which mechanism is relevant and whether treatment's going to work. So inflammation in the airways or the lungs is a potential mechanism. It will activate the cough receptors, and this is more likely if there's mucus, infections, or coexisting inflammatory conditions such as asthma. The one that we often discuss is the direct effect of scarring in the lungs. So this is mechanical, so distortion of the lungs. There are several different types of cough receptors we have that are important sensors, and one of them is a stretch receptor, and it will detect mechanical signals. And it's possible that this goes into overdrive as the lungs scar. Another possible mechanism is reflux. So this is regurgitation of contents of the stomach, liquid or food, and this is regurgitation up into the gullet or into the throat, and even worse, into the lung. And this is how it will potentially cause cough. Reflux has also been proposed in a number of patients to be the direct cause of fibrosis too, when it's aspirating directly into the lungs. Another more recently recognized cause is a hypersensitivity of the sensory nerves, and this is a very active area of research in patients with just a pure chronic cough condition. It's where the sensory nerves and the receptors, the sensors, become hypersensitive, and fibrosis cough does seem to have this feature. We mustn't overlook other causes of cough other than the fibrosis. Next slide, please. Because chronic cough is a common disorder in the general population, and in patients without chronic lung disease, common causes are in the bottom half of this slide: asthma, reflux, or the Americans call it GERD in this slide, and rhinitis or sinus problems, and the Americans label this as upper airway cough. This was data from the US, and in this specialist clinic, they proposed that approximately in half of patients with pulmonary fibrosis, the cough was due to the fibrosis, and in the other half, it was due to other conditions, common conditions that respiratory physicians manage. So next slide, please. So how should we treat cough due to fibrosis? Well, first we should treat the fibrosis optimally, and this could be an antifibrotic where relevant, an immunosuppressant medication for a connective tissue or autoimmune disorder. But if the cough persists, then what should we do? And this is a guideline that I led with working with colleagues from the Mayo Clinic in the US. And this is the American College of Chest Physicians guideline group, where we proposed some recommendations in assessing and treating patients with cough who have fibrosis. It may not surprise you that we found few studies of quality to support recommendations, but we had, but we wanted to provide some guidance on what evidence and opinion was available, because it's such a problem for patients. So next slide, please. And what we suggested was, so these are patients with refractory or persistent cough due to fibrosis, where the underlying fibrosis treatment hasn't helped the cough. So what we suggested was to follow another guideline that I've developed with colleagues for patients with a truly unexplained chronic cough. And the way we manage that is, well, there's three suggested therapeutic options here. One is to try medications that calm the sensitivity of the cough reflex. They work in the brain, and this is a drug called amitriptyline, widely used in primary care for treating pain. An alternative is gabapentin, and these do have some success in patients with unexplained chronic cough, and therefore this data has been extrapolated for patients with pulmonary fibrosis. They do have side effects of drowsiness, and that's why we have to prescribe them with caution. Now, another therapy, I've called this cough control therapy, and this is delivered by a speech or voice therapist or physiotherapist. It's worthwhile in my experience, and it's a therapy where the speech therapist identifies triggers and advises patients of how to manage and suppress those triggers, and other breathing and cough techniques to deal with the condition. A third option is morphine-like drugs, and these can be effective in a low dose in some patients. So next slide. So I'm going to move on to new treatments, and these are this is a list of treatments that have either been evaluated recently or currently being evaluated in trials or are shortly about to be evaluated in trials. And this is very exciting, and I will cover some of these now. Next slide, please. Yeah, you may ask, do antifibrotics help? And in this study, small study, a collaboration between 4 European countries, and we did the cough monitoring for this study. We evaluated pirfenidone and measured cough objectively with a digital cough monitor. And the data here is individual patient data, and it's the cough counts. And as you can see, in about 2/3 of patients, there was a reduction in cough counts with pirfenidone over a 3-month period. This hasn't been evaluated in a proper placebo dummy randomized controlled trial. In my experience, in some patients, there's a modest cough suppressant effect of antifibrotics, but this does need further study to confirm. Next slide. Now, the most exciting drug that's being developed in the field of chronic cough, and I'm referring now to patients who don't have fibrosis, is inhibitors or blockers of a sensory nerve receptor called the P2X3. And there's four drugs in development. The most advanced is a drug called gefapixant, made by Merck, and this has now completed its phase 3 trials and is sitting with the regulators being assessed for or being considered for licensing. And this works really well in my experience in the trials that I've been involved with, and this is very, very exciting. It works very quickly. It's well tolerated by most, and there are no serious side effects, and certainly no drowsiness because it doesn't cross the blood-brain barrier. There has been one small study in patients with IPF fibrosis, and unfortunately, this trial was negative. It didn't meet the primary endpoint, which was reduction in cough frequency. However, there are some caveats to the findings reported in this study. They didn't analyze the cough frequency data in the correct manner. Therefore, they did add another form of analysis, which is more appropriate, and that did show a trend towards a reduction in cough. And what I've shown here is another figure that shows that patients who responded on gefapixant versus placebo, and we're looking at 20% reduction in cough, 30%, 50%, 70%. But whichever degree of responsiveness we look at, patients always did better with gefapixant compared to placebo. So I'd hope when this drug becomes licensed, and it won't be available for fibrosis initially, but we would need to do the studies and prove it works, and then hopefully make it available for a wider range of conditions. So this is one of the most promising medications in development for cough. Next slide, please. Now, an ongoing trial at the moment is the CANAL study, and a drug called nalbuphine. And this medication targets opioid receptors. These receptors are the targets for morphine-like drugs, and this drug apparently has more specific targets on the opioid receptors. There are several opioid receptors having different functions. So this company proposes that they may be more effective than morphine, and possibly less side effects. But this is an ongoing study of a real interest, and we eagerly wait to find out if it works and if it has an acceptable side effect profile. Next slide, please. Now, another exciting trial about to start early next year is It's a medication called orviprepitant, made by a company called Neri, and this medication blocks the nerve signal transmission for sensory nerves, and it's thought to be an important mechanism in cough. It acts in the brain and the nervous system, and this is a multi-center trial between the US and the UK. So for those interested, please do get in touch with your local teams if you'd like to participate. There's likely to be a few UK centres taking part. Guy's hospitals are likely to be one. Next slide, please. So in conclusion, pulmonary fibrosis or interstitial disease associated cough is very bothersome, severely impairs quality of life, both for the patient and their family and friends, and disrupts work. The mechanisms can be challenging to establish and can be unclear. But we should always consider other possible causes for cough, such as asthma, reflux, and rhinitis. Antifibrotics may be effective for some patients. There's evidence, research studies that do support a role for heightened sensitivity of the cough sensing nerves in IPF, and this may be a promising mechanism to target for future research and develop treatments. The good news is that pharmaceutical companies are very much interested in developing or evaluating new cough treatments in IPF in particular, and I'm hoping this would lead to better treatment options in future. With that, I'd like to close my presentation and would be very happy to take questions.
Great, thank you very much, Surinder. That was wonderful, clear, and I think a really good basis for the discussion that's coming. We have a number of questions already in the Q&A. There are 220 of you here now, 226. So let's have a few more questions as well, if you would. And in response to the question, we will be sharing the slides afterwards, but we'll be recorded. This session is being recorded, and it will be available on the APF website later. So now I'd like to introduce again Liz Robertson, who's, as we said, an RA-ILD patient who suffers from cough. Well, welcome, Liz. First question, Liz, when you hear what Surinder had to say this evening, does it resonate with your own experience of living with chronic cough?
Yes, absolutely, Steve. Yes, it's really helpful to hear it sort of from a more medical view, because it actually confirms all the things that I think I and so many of us in the support groups and so on actually feel and experience. Certainly for myself, I have the sort of long-term dry cough that seems to be the pulmonary fibrosis type of cough. But then you experience different coughs, don't you? It's not just one, because you might be having an episode of reflux, as you mentioned, or you might be having an allergy, an allergic reaction to something. So you can experience lots of different coughs, and it's sometimes difficult to know which is which, but actually, to a certain extent, it doesn't matter, because the cough is there in some form or other and affects everything.
Yeah, that's interesting. When I had IPF cough throughout the 8 years I lived with IPF, which is the tickly, persistent cough. But for the last, I guess, 3 or 4 years, I was producing huge amounts of phlegm, every day, and sometimes really very difficult, almost gagging on it, and it was really horrible. But that, I think, in a way, is, I'll ask Surinder in a second, but it is the body's reaction to getting rid of stuff. That mucus is being produced where it shouldn't be. It's being got rid of by the lungs, and that's part of the cough, the experience of the disease. But think about your own experience, though, Liz. I mean, how does cough make you feel?
Well, it's difficult to say that in a few words, so I will try, Steve. But there are so many different aspects. There's the physical aspect, because people don't realize, unless they're going through this, that it's painful. If you're coughing and coughing and coughing, and you're trying to clear that tiny bit of phlegm all the time, or, as you say, horrible amounts of phlegm. But if it's persistent, you're exhausted, you're in pain. We know people who've had cracked ribs as a result of persistent coughing. We know people who basically just cannot deal with it at all and become very, very depressed. But it affects every part of your life, doesn't it? I mean, when you're coughing like that, you can't say to a friend, oh, let's go and see the Bond movie and have a pizza afterwards. You can't go and sit in a cinema. You can't go and sit in a restaurant. You can't go and visit a friend who's got a log burning stove or an open fire. Mind you, if you're on oxygen, probably you shouldn't be doing that anyway. I would just point out health and safety. But you are limited to so much, but you're also irritating people. You irritate your family. You irritate people you're trying to talk to on the phone. And sometimes they'll be patient and sometimes they won't. It just depends on the situation. In my own case, the cough basically meant that I had to give up work, because most of my work was on the phone and talking to people. And apart from the breathlessness, it was the constant cough. People would constantly be saying, oh dear, you've got a cough again, you know, and giving you great advice as to which cough suite to try. And it's frustrating. It's difficult, isn't it?
Yeah, I was still working right to the end with IPF, and I had one of those spider phones with the mute button, and my finger hovered on the mute button. So whenever I was talking to a client on the phone, I would go on to mute if I had to, because it was so embarrassing. It was really difficult. But
Steve, talking about embarrassing, I wasn't actually thinking of mentioning it, but Surinder did right at the beginning. And that is, there are other physical effects of persistent cough. And one of them is incontinence. And that, for people who are having really long spells of it, is a really debilitating, miserable experience. So I'm just so excited to actually hear about the research that Surinder's talked about, because I think that's going to be phenomenally positive for some of us. It's easy to say, oh, well, you can try controlling it, you can take your cough suite, you can do all of these things. When you feel fairly well, you can do that. You can get a bit of a grip. You can think about what you've been trained to do, your breathing, your how to swallow down the cough, all of these things that can be learnt and can help. 3 o'clock in the morning, when you haven't slept, you can't do that. It's just debilitating and depressing. And I'm not trying to be depressing about it. I'm just trying to say that's the patient experience of it. And it would be so nice if we could get other people to understand we're not infectious, we're not contagious, we're not being deliberately difficult, we're not spreading COVID around the supermarket. You know, people get such horrible responses at the moment, dreadful things said to them in shops. Oh, it's really, hearing what people have said is so sad. How we get that over, I don't know, but hopefully APF is doing a great job tonight, and the research that Surinder is involved with is really fascinating.
Did you find you got any top tips? The trouble is, we all experience a cough differently, and we probably have many top tips that we each use to how to overcome it. I mean, what do you find helps?
I find that the sort of the usual things like having a glass of water, sipping regularly, having a sweet that you could, not a cough sweet, but just an ordinary sweet that you can suck sometimes helps. Yeah, exactly. So I have my supplies here. And for me, I know it's not necessarily an approved medical thing at all, but for me, I avoid milk products in the evening. I don't have anything milky because that seems to make me very cough a lot more. I know that some people in our group are finding an air purifier, a good quality air purifier, can be incredibly helpful.
Yeah, one of your group has mentioned that in the chat.
Right, yeah. And what other things? The sort of things that you can learn from a physiotherapist who deals with this, or a speech therapist who deals with cough. I was very lucky to see somebody just before COVID and learned about trying to retrain the nerve that responds so automatically to the wanting to cough, and how you could actually, by breathing, swallowing slightly differently, and also relaxation, could try to suppress it. So those are the sort of things. Are they the same as yours, Steve?
Very, very similar, really. I think it's I think there's certain things I don't really want to talk about on here. You know, the kind of things we do to manage it. But it's, I think everybody I talk to, it's something different. I mean, there was a question. I mean, I don't know, Surinder, maybe you'd like to come in now and respond to what Liz has said. Are there things that you feel worth emphasizing? Or
yes, Liz describes many of the problems very well, and also some great questions in the chat, all highly relevant. But most patients always carry a bottle of water is standard in your bag, but during cough sweets, some patients find fisherman's friends can be helpful. It does vary from patient to patient. Or menthol containing sweets. These are practical measures, and a speech therapist, or particularly with an somebody who's a more voice therapist, because there are different types of speech therapists. Some are trained to do swallowing disorders. But it's the airway voice therapists are the experts on vocal cord cough and breathing related problems. They can teach some of these maneuvers, how to manage the cough. A respiratory physiotherapist can also be very helpful. And I see mucus or sputum phlegm keeps coming up. Many questions, and that is troublesome and difficult to treat. But things that you can try is a respiratory physiotherapist to teach airway clearance exercises. They do have a device, a flutter device, for example, that can help some patients clear their phlegm. Remaining as active as possible. Exercise obviously helps mucus clearance. Carbamazepine is the drug that's been mentioned. It's thought to break the mucus bonds and loosen it and make it easier to come up. So that's an option for mucus. And we find, well, certainly in the published studies, the prevalence of coexisting asthma, COPD, or emphysema is pretty high in IPF conditions. So one should always pay attention to, is there a degree of emphysema on the scan, and whether some COPD inhaler treatments may be appropriate, particularly anticholinergic type inhalers can act on the mucus glands. So yeah. So those are just some practical tips. Or a relevant therapist that may be able to help you with practical things.
Thanks for that. I mean, there was a specific question on carbocisteine about, it was recommended to this person by a helpline. It's helped me a lot. I mean, I benefited from carbocisteine too when I was a patient. But I was wondering if it's okay to take this drug virtually forever. I have pulmonary fibrosis and emphysema, bronchiectasis, and asthma. As you were saying, comorbidity's got a lot almost, sadly. And a minus a third of my right lung. So one or the other caused thick phlegm that settled in my lungs and caused me to cough all the time.
Yeah.
I generally worry about whether carbocisteine can be taken long term.
I tend to start with on a trial basis and try and recommend trial for a couple of months and definitely stop it if it hasn't worked. So only continue longer term if it's definitely improving your condition, and if it has improved and you're happy to take a longer term, then that's okay. It should be reduced. You should with your GP work out the lowest dose that maintains symptom control. Because it's often 3 times a day and a higher dose to start with, and then tapered accordingly.
And another question, one which I was going to ask myself as well, was you mentioned gabapentin and amitriptyline.
Yeah.
How do they actually work?
Yeah, it's surprising. The mechanism of action of gabapentin, even in pain, for which it's licensed and used widely, is poorly understood. Where it was originally developed as an anti-epileptic medication, but it's hardly ever used for that now, and it's used for pain. And pain and cough are very similar conditions. They share the same mechanisms. It's the same C fiber nerve, similar receptors, and similar connections in the brain. So pain and cough are very similar. And that was the rationale why we looked at gabapentin in cough. And Peter Gibson from Australia and we worked on a study at a trial in the chronic cough population, and that was the first positive study in chronic cough published in the Lancet. We think it works in the brain and reduces what we call central sensitization. So we have a upregulation or a wind up of the sensitivity of the cough sensors out in the airways or the throat, but there's also a wind up amplification of the signal in the brain, and it probably calms that down. It doesn't work in everybody, and in many patients it can cause side effects of drowsiness. So you have to the trick with gabapentin is to gradually increase it, be patient, and definitely stop it after a couple of months if it hasn't worked.
Yeah. Thanks, that's really helpful. There's, I mean, a number of points raised. I think Liz did as well a bit. Is we have problems often when we lie down at night. It's often, or even in the daytime, it's difficult sometimes because you want to rest, but your cough stops you. But we all know that PF patients don't ask to organize any meeting, before 10 or 11 in the morning, because it takes a long time to get over the cough and everything associated. I mean, one person talked about how it's 20 minutes of really hard coughing and then a breathlessness and a very difficult 20 minutes recovering afterwards.
Yeah.
I mean, what can we do to help these really sort of well, not exactly crisis, but crisis in inverted commas.
This characteristic of cough is also very common in patients with another condition we call cough hypersensitivity syndrome. These are the pure chronic coughers who don't have any lung disease. This is the reason why it makes me think that many IPF or IL pulmonary fibrosis patients had the same problem. They just coexist, maybe driven or initiated by the fibrosis. So cough worst in the morning is characteristic in other other disorders. Also when laying down, where we don't understand and it's difficult to prove what's causing it. Possibly retention of mucus, as you mentioned, for the first thing in the morning. Possibly draining of mucus when you're lying, changing posture and lying down. Others would say it's reflux, heartburn, because when you lie down, or when you get up first thing in the morning, is the action of getting up. The valve between the gullet and the stomach relaxes, and it lets out lets out and regurgitates up backwards, leading to cough. So those are probably the hypothesis. And maybe first thing in the morning, the airways are also more hypersensitive because of the colder air. So those are possibilities. Practical measures for those problems is similar to the cough itself. It's what we use for cough.
I mean, some people have talked about using air purifiers, things like that. Is that something that you'd recommend, or you do recommend to patients? Or
we don't. We haven't, and no one's really studied it in a scientific manner. And I've been running a specialist cough clinic for many years, and rarely do I see patients come back with a spectacular effect. I think I wouldn't say no. It's not going to do any harm, and if you're comfortable with it and it works, then absolutely. I think there was also a related question about air pollution. I can imagine air pollution being a trigger. We have a wide range of different types of cough receptors, and many are irritant receptors, and their job is to sense the air that we breathe in. So, and I'm sure pollution is a big factor in causing chronic cough, asthma, emphysema, and other conditions, or may not be the cause, but a driver or persistence of symptoms. Unfortunately, in my experience, many patients do move to in our hospital to the Kent coast, and some get better and some don't. So it's difficult to predict who. So I honestly can't recommend a major investment and lifestyle change. But if there's a good excuse to do it, then go for it.
I certainly always feel when I'm by the coast, I breathe a lot better than I do when I'm in that.
But is it because you're more relaxed, stress and anxiety?
It could be that. Yeah, who knows?
As Liz mentioned, absolutely big factors in driving cough. A key mechanism we've learned recently, Peter Cho, who's now my colleague at King's, did the work, is that patients with chronic cough, they not only develop a hypersensitivity of the cough sensors, the nerves, but they also have inactive or less active areas in the brain that are responsible for inhibiting cough. So we do have this sensitive pathway, but also a break in the brain to stop these signals leading to a cough. And these are just natural mechanisms. We all have them, and this filter stops the coughing. But in patients with a chronic cough, they lose this inability to break their cough, and those who are particularly anxious and stressed, they don't. I think they don't have the ability to control their cough as well. It's not the cause of their cough, definitely not the cause of their cough, but so part of speech therapy, voice therapy, or physiotherapy is stress management, and it's a key part of their armor.
Yeah, there's an interesting question. One, I mean, Liz was talking before about things you can do you learn to do yourself. One thing I learned, I used to cough always on the telephone. So why I'd use one of those speaker phones or whatever, was that I could talk more naturally. If I try and hold it to a phone like this, it would also always produce cough. And I found the way I could solve that when I was taking oxygen, supplementary oxygen, was if I put supplementary oxygen on, it would help me cough less. And a friend of mine from Cambridge has just said, with exertion, I cough violently through lack of oxygen, particularly getting ready for bed and first thing getting dressed in the morning. So it's that sense of breathlessness. It's not just it causes it, but it also seems to exacerbate it. I mean, there's something going on there. Do you
absolutely. Cough disrupting speech presentations is also a very common problem, and people do change jobs because of it, unfortunately. When we're speaking, we're putting our vocal area where there's a high concentration of cough sensors under stress, and we also have more turbulent air and more turbulent breathing. or compounding and stimulating the cough receptors. So practical measures are usually taking sips of water, and if the voice component of the chronic cough problem is severe, then it's worthwhile seeing a voice therapist, because vocal cord dysfunction is described in up to 50% of patients with chronic cough, and they do have effective techniques to address that. So that isn't a treatable aspect. Now the breathlessness you mentioned, Steve, due to the cough itself, is very common. So sometimes in the most severe cases causes laryngospasm, so choking. It's just the throat, the larynx just closes off. Again, seeing a therapist, a physiotherapist, or a speech a language therapist is very helpful. It's just the larynx going into overdrive, and it's still overstimulated, and the techniques to relax the muscles do help.
I think, can I?
Yeah, come in, please do. Yeah, I was going to bring you
on that, Steve. I think that's really important, because I didn't mention, but as you've just said, coughing and choking is something that I think affects a lot of us. We get used to it. We don't really notice it until somebody else says, you know, you're coughing on your toast again, you're choking again, you know, eat more slowly or do something, but stop getting to that choking point. But that was something that, as you say, the speech, the voice therapist, physiotherapist was able to help with enormously. And I very rarely now actually choke on food. But there was a time where, you know, if you'd suggested I had rice, for example, couldn't do it at all.
Okay.
But that can be sort of helped with the therapies.
Absolutely.
Yeah.
Somebody mentioned oxygen cause exacerbating their cough. Trevor, I think. If you don't, the addition of a humidifier can be helpful to moisten the oxygen. Can reduce cough.
That's good. Yeah. Another person said, I suffer from debilitating cough with pulmonary fibrosis and regularly vomit, as well as causing subconjunctival hemorrhage from the coughing. Will these hemorrhages damage my eyesight over the longer term?
They shouldn't do. I haven't seen somebody with permanent eye problems, but somebody also raised syncope, so passing out similarly, or will cough damage the lungs. We don't. I mean, there is debate about whether it damages the lung. Probably not, in my opinion. And probably won't damage the eyes or others, but they are very extreme symptoms and well recognized with cough. And the treatment is to try and address the underlying problem, which is driving the cough, or non-specific or just general cough suppressant medications is the way to deal with those.
I mean, a friend, I think this is a rhetorical question almost, down in Wales, says, I seem to cough in more prolonged and exhausting manner when I'm on my own or with my family. When I go out, I can somehow control it more when I'm with the company of others. Is this habit psychology of coughing? Is it something that you, in fact, can get that sort of psychological control of? And is there any way you can help people? Or is it, he says, is it just me that does this? So.
Habit or psychological, or also known as tick cough, a variety of terms used. It's mainly a condition limited to a small handful of children with chronic cough, and I don't recognize it in adults with chronic cough, in IPF or other conditions. I think most of my colleagues in our field would agree. And unfortunately, the label of psychogenic or habit cough is usually a consequence of a poor understanding by the doctor or patient, or unfortunately sometimes indifference by the doctor, or being dismissive about the seriousness of the problem. So the reasons I alluded to earlier, stress and anxiety I wouldn't say they're the cause, but they can make a big difference in helping manage the condition. So possibly if you're outdoors and you're more relaxed, breathing better, so less deeper breathing from the diaphragm rather than the upper chest, is less turbulent to the throat and reduces the cough. Nasal breathing through your nose is much better than breathing through your mouth. And these are again techniques helped by the therapist, so those may be reasons why the cough is better in that situation. But habit or psychogenic cough is extremely rare in my hands.
Okay, an interesting question though about you mentioned about this mechanical stresses in the lung caused by the scarring being a source of cough. There's a question about whether chronic cough can, using the same kind of distorted mechanisms, actually exacerbate IPF or exacerbate the process of fibrosis. Is it a two-way street, or is it a
that notion has been proposed, and there is a study from North America years ago that did show coughing was associated with more progressive disease. There's really been a paucity of studies and information on this. I don't think there's no clear relationship. So I would caution against coming to the conclusion that cough is damaging the lungs. And the sort of damage that we see due to coughing is hernias, for example, troublesome, muscles being pulled, blacking out, and a black eye. For example, vomiting, incontinence is probably the number one in female patients. But damaged lungs, I think it's unlikely.
Liz, do you have any reflections on what you've heard from the Q&A so far? Does it, what gels with you, and what sort of challenges the ways you've been thought about things before?
Yeah, I think it's just interesting to see how varied people's experiences are, and yet with some core elements that are the same. But it's I find it quite worrying, I suppose is the simple word, that so many people are having such grim times with their cough, because there's the rest of the condition to worry about and deal with, and the breathlessness and all the other aspects of having pulmonary fibrosis in any of its forms. And having to really struggle with the cough is a major lack of functionality in your life, isn't it? And
it really affects the quality of your life.
The better. But there are some, I think we've heard a lot of things that do give us some hope, and there are practical things we can try. They're not going to work for everybody, but somebody may find something that helps them, and that's what sharing this sort of information is all about, isn't it?
So it's about talking to your doctor, asking to be referred to a speech and therapist if that's appropriate, or whoever, a physiotherapist, to help you with the problem. This is sort of speaking rhetorically to you, Surinder.
Steve, just one thing, if I may mention, which I didn't address in my slides, because it's more. I don't tend to see many patients with this problem, but there may be many patients affected. It's blood pressure medication, ACE inhibitors, angiotensin converting enzymes. So examples being ramipril, lisinopril. So if you have cough, whatever the cause, and you're on that drug, you should always consult your GP and try and switch it to another blood pressure medication without this side effect. It's a class of effect for ACE inhibitors. Even if it's not the root cause of the cough, it amplifies it, and very commonly stopping it makes a big difference. So
thanks for that, because one of my 2 blood pressure pills is an ACE inhibitor, so I should get off it quick. But the other thing about the trials, we've got the Canal trial is recruiting at the moment. I think it's at about 12 excuse me 12 centers in the UK. You can find out more about that on our website. The NERI one, the orvepitant one, which is coming in the new year. Again, APF, we will put it on, inform patients about that when it comes. But your route to these trials is through your consultant at the hospital, who can then refer you, if appropriate, and if it's possible. I think I'm correct in saying that.
Yes, yes. That would be a good route, and I think if Action for Pulmonary Fibrosis are able to help point, because I'm sure Steve and colleagues will know the 4 or 5 centres that will be doing the trial, and you can always point patients to that centre, and then often a GP may be able to refer you up to that centre just for consideration. You may not need to go through their clinic system. You may have a trial practitioner or nurse that may screen you and check suitability. So yes. So
talk to your doctor, talk to us in APF, and we'll help you if need be. It varies from hospital to hospital. Some hospitals welcome individual approaches, others don't, and we'll see how that goes. Sadly, for the gentleman from South Africa who asked, I think you'd have to be on a trial, you'd have to be in your own country. I don't think you can do this remotely, so it's worth talking to your consultants. I'm sure that in South Africa there are many trials as well on IPF and other forms of pulmonary fibrosis that it would be good to go with. A final question for you, Surinder. Why are there so few cough clinics in the UK?
It's a historical problem. I would love to have many more, so patients don't have to travel so much. It's unfortunate. It was just it reflects the lack of investment in the field historically. And that includes drug development by pharma. Having said that, the UK is the leading country in the world. Whilst most of the research into new drug development comes from the US, they have to come to the UK usually to do the research. So they're very good cough centres here. I think we are on the cusp of something really big if gefapixant and the other P2X3 inhibitors make it, and we will have an outcome next year if they are approved, and the next hurdle will be a big one. It's persuading NICE to pay for these drugs, and even though they are for refractory coughers, it will be a big game changer, and I'm sure we will see a lot more cough clinics. We are in cough where IPF and ILD was, say, 10 years ago, Steve. There were only about 3 or 4 of us centres doing with specialist clinics.
You've got yourself at King's, Manchester, Hull,
Belfast, Leicester, Oxford. There's a Northumberland.
Northumberland, and the story basically is it's for if your local consultant exhausts all possibilities for you, that's the time when you can ask to then be referred to one of these specialist centres.
They generally tend to specialise in the refractory or the cough hypersensitivity patients more than the lung disease patients, but I think some will see patients with underlying lung problems.
That's great. Good, thanks. Liz, any final words from you?
I think I feel sad about the people who are struggling, and I feel much more optimistic about there possibly being solutions. And some of them may not come in time for all of us, but if they're there for the next people coming through, then that's fantastic. And as much as we can do to promote the research and support it in whatever way we can, be great.
I think it was a really good choice for APF to make this the focus of PF month this year. I mean, it's a real, I did a meeting, a pharmaceutical meeting, where the person came, it was going very slowly, it was quite boring, a lot of patients around the table. And then at night, it's 9:30 on a Sunday morning, in came this doctor from the company to talk about cough. And suddenly the room exploded. Everybody wanted to talk about it. It's like the elephant in the room that we've been ignoring for too long. So I think bringing it out in the open is really great. So look, Surinder, I'd like to thank you for your brilliant talk and the way you've handled all the questions and helped us understand this much better tonight. And Liz too, for generously giving your time to be with us and for contributing so valuably to the meeting. The audience, 78 of you have put questions in the Q&A. I'm sorry that we couldn't reach all of you. If there's anything which you really would like to know more about and you can't find it on our website, then get in touch and we'll do our best to find out or to connect you to somebody who can answer it. We'd like to thank you all for your active participation tonight. Hope you found it useful. For further information, as I said, is on our Managing Cough part on our website. The session tonight has been recorded and will be available on the APF YouTube channel. So go to that if you want to hear it a second time. And shortly afterwards, we're going to send you an evaluation form, and we'd be really grateful for your constructive feedback to us so that we can improve these webinars to be of even greater use in future. So as I say, contact the APF support line if you've got any further questions. Thank you, Surinder. Thanks, Liz. And a very good evening to everybody. Thanks.
Thanks for the opportunity. Have a good evening. Bye-bye. Bye, Liz.
Bye-bye.